Hello and welcome to COPD Wellness. We're your hosts, Angus and Russell, and on this podcast we talk to medical professionals and COPD patients to discover just what living with a lung disease is like, the effects it has on you mentally and physically, and how it affects those around you. This episode is proudly sponsored by the National Asthma Council of Australia.
Here we are, folks, for episode 2 of the COPD Wellness podcast. Today I'm joined by Stephen Hughes, who's a pharmacist. Stephen, welcome to the program.
Oh, thank you very much, Russell. I'm really happy to be here.
I guess for the audience at home, can you explain a bit about your experience, your qualifications, and how you come about being a pharmacist?
Yeah, so I'm a pharmacist, a community pharmacist, which means, yes, I stand in the shop. That's the basic stuff. My qualifications went through something like 25 years ago or so, and I still do stand in a pharmacy. I do a little bit of teaching of pharmacy students nowadays as well, and also I've embarked on some further research into chronic condition management as well. Your second thing was, why did I want to become a pharmacist? It's a pretty good question. I think the basic answer is I was good at science at school, so I went from there. Keep it simple. But I guess what really attracted me to the community pharmacy is it's very accessible sort of practitioner. You're really there in with the community as part of the community, and you're not really locked off in a room behind a receptionist. You can be accessible at any time, and I just found that an appealing sort of workplace that you could be, people walking in at any time, and you could talk to them. And I've certainly found that very beneficial throughout my working life as well. That you are very accessible, and you do develop some very good relationships with people because they can sort of walk past and wave and say, yeah, all's going well, or not so good today, or however that turns out.
And it's interesting, I guess, being at that sort of level, you get to build a relationship with patients, and whether that gives them the opportunity to, or they feel more comfortable in discussing things with their pharmacist that might help you.
Yeah, I think you're probably right there, Russell. I think we pharmacists see patients or members of the community more often than they probably those people see any other practitioner, I would say. Certainly people that are on regular medication, because you're coming in every month or two, and whatever in between. So it's kind of nice. If you're in a small community, you do get to see all the different generations as well of the same family. Sometimes you don't find out for many years that that they are actually in the same family. But it's that sort of accessibility and frequency of contact is a real benefit of pharmacy. So yeah, as you say, you do become a big part of people's lives.
I could understand why that would be an attractive place to work. So as far as medication is concerned, when did you become involved in, or when did you start getting interested in medication and respiratory patients?
Yeah, so I think in the let's say 25 years ago or so, I saw when I first started that inhaler medications were a really big part of some people's lives, and they were quite a burden for some people. Back in the old days of shorter acting medications, so people would 4 or 5 times a day, they were, if they had a fairly severe kind of condition, they were tipping the liquids into the nebulizer bowls and then sitting down for 15, 20, 30 minutes 4 or 5 times a day to take their medications. And even those that were taking them out of inhalers or through spaces and things like that, that was a pretty significant part of people's days. And I found that, talking to people, they said it was a real burden. And then for others that, perhaps weren't taking things quite as often, they seemed to manage quite well. So I guess that sort of piqued my interest as, how could pharmacists or myself, support people and, make a difference and help it be less of a burden and more effective. So I guess that was the kind of it was a little bit of low-hanging fruit too, because you see that a lot of medication or inhaler mistakes were being made, and that was really affecting people and making it more of a burden than it should be. So target to make a bit of a difference, I guess.
Yeah. I guess, I mean, in that time you've been involved with respiratory medication, have you seen a lot of changes in medication, how they've developed and whether they've become easier for patients to use?
Yeah, I think that's a good point. It's not so much that there's a lot of new stuff out there, or as in new things that are really going to change the world, but the way that they're delivered has definitely changed. So, yeah, new drug molecules, and they're a lot safer now, and the doses we can use are smaller, and there's all those sort of benefits, so the side effects are less. But I guess some of the other benefits are that we don't have to take them as often, so just taking them once a day or twice a day is very real for a lot of people, and that a simple inhaler that you can use once a day, it takes a matter of seconds if you do it properly, and then you can set and forget and not think about it till that evening or the next day has been the great leap forward, I think. And there's also combination medications as well. So where previously you'd have to take two medications, you put them all in together and you take the one, it's a lot cheaper for people and a lot less burdensome as well.
Yeah, I remember as a kid, I was an asthmatic child, and I remember the amount of times you would spend on those nebulizing machines. And certainly people still have to do that, but I think with the technology available these days, it's becoming less and less.
I think the other thing too, Russell, is that we know a little bit more about, well, we certainly know a lot more about respiratory conditions, and previously there was more of a fear, I think, amongst practitioners as well as patients. I mean, patients certainly had the fear, but practitioners as well, so they're probably more concerned of making sure people had enough dose on board. So, if you're taking a lot of some medications, you get a lot of side effects. So you might be shaking a lot from too much Ventolin, or you might be having side effects from too many steroids. But now we know a lot more, and we know that the medications are safer, and the dosages are more accurate, and the molecules we've got a lot more specific, and we know more about that there's sort of a maximum amount that you can give people before the effect doesn't really increase anymore. And now that we really talk about this whole ideal of giving people the smallest dose that gives the most benefit, as opposed to in the old days it was probably just give people a lot because we want to make sure they're safe. Now we know a small dose that can still give a lot of benefit can be a lot safer. So I think that's sort of individualized, tailored medication that you're sort of actively managing it, thinking about it either yourself or in collaboration with your practitioners, and saying, well, let's get this down to a small dose that keeps it as effective as it possibly can, but reduces any burden on me and any expenses and any side effects and all those sorts of things. So yeah, we're a little bit cleverer now than we used to be.
Yeah, it's interesting. I'm sure that there's patients out there when they're having an exacerbation of their disease that they may think that they take more medication to help relieve those symptoms, but sometimes that more medication may not be making any difference. It's about the delivery and the effectiveness of that single dose.
Yeah, that's exactly right. Delivery is where it's at. It's not as easy as taking a tablet. And I think that's probably where practitioners and patients as well can really fall down thinking it's simple. And as the inhalers get more theoretically easier to use and foolproof, we kind of realise that actually no, they're not really. You still need to know what you're doing. You still need to do it well. So it's getting the right medication where it's needed, which for respiratory conditions tends to be deep down in the airways, not right up the top. And that means you need to go through a lot of the correct steps to get that exactly where you need it. So what I said before about having those small doses, if we're going to have small doses, we need to be able to use it well as well, so they get to the right area.
Yeah. As far as respiratory patients are concerned, what are the main pharmaceutical interventions available, and the types of medication, and what are they actually targeting?
Yeah, I guess we always talk about preventers and relievers. Does that sound familiar?
Yes, it does.
Yeah. So I don't know whether they're actually really good terms, but they're the terms we use, or certainly the terms that are used in the medical profession, and that's supposed to be the terms that people that have the conditions use as well. I don't know what would be a better term. Sometimes I think preventers should be everyday treatment or ongoing treatment or just treatment, and relievers, I don't know, what would you say would be a good term for relievers? What does it do to you when you need it?
Well, it relieves your symptoms. I mean, it's funny, isn't it? Because, we would rather talk about preventative and not relievers insofar as our preventative medication allows us not to have to use relievers, I guess, if that makes sense.
Yeah, no, I think that's sort of hit the nail on the head. I guess before you sort of talk about what are the medications, you kind of need to really understand what's actually going on inside your airways, and for the most part, there is inflammation in airways, and that's for people with respiratory conditions. For most people, certainly with asthma and sometimes with COPD as well, there's inflammation. With COPD, more you're seeing more what we'd call structural issues, where it's
like a fixed obstruction.
Yeah, so it's not necessarily going to get better.
Mm.
So you do your best, but it doesn't mean you can't treat it. So preventers, we talk about things you take every day. So for asthma, it's anti-inflammatory medications. So you got inflammation, and you got your airways that they're a little bit sort of jumpy. So if you come across some pollens or dust mites or wind, or you get a flu or something, and they react more than other people's airways. So ongoing, it's taking something that stops that inflammation and stops that jumpiness. So that's preventers, and they do tend to be what we call corticosteroids.
Mm-hmm.
So very specific, low dose, and super clever anti-inflammatories.
Mm-hmm.
And I don't need to tell you, but sometimes people still get those mixed up with other types of steroids, and they're certainly not anabolic steroids or anything.
No.
They happen to share a similar sort of name, but they're very different sort of things.
Mm.
So that's the corticosteroids, and you'll see things like Flixitide as brand names, the old Beclafort and
yes,
names like that. Yeah,
yep.
so they're the preventers.
Mm.
Now, the other ones, what we called about the relievers, they basically relax the muscles around the airways. So when those muscles are all tight and they're squeezing, and they're making the pipes, which are your small airways, the space in between them really narrow, so you can't get air in and out, especially out. They relax the muscles and allow the space there to be a little bit wider. So when you've got an issue, as in you do go outside and you breathe in some pollen and it makes your jumpy airways twitch, then the relievers, they're the ones that you have to fix that straight away. They last anywhere between 3 or 4 hours, and they usually work within a minute or two.
Okay.
Preventers, different sort of thing. So I guess we'll stick with that terminology for preventers and relievers because it's easy.
People understand that, I guess, more.
Yeah. So, but sometimes you have to think of the preventers as treatment. So that's your mainstay of your treatment. That's the things that you get up in the morning and you take to keep you going, to get you better. Ideally, the relievers you don't use too often. There's a little bit of a trick with this, and I was saying with COPD, often we don't use the same sort of steroid preventers for COPD because you don't have that sort of level of inflammation there, which is different to asthma. So what is used for COPD is like a reliever, but it lasts a lot longer. It lasts sort of 12 hours or 24 hours, and that does that same sort of thing. It relaxes the airways, opens it up, and allows you to breathe a lot easier.
So are we talking medications like Symbicort or Spiriva or are that?
Yeah, Spiriva.
Yep.
Spiriva, Ceravent, Oxys.
Yep.
And some of the new ones. So they're long-acting medications, and there's also the joint ones now too, where you've got two different types of relievers in there.
Mm-hmm.
We call them symptom controllers. So I guess from your perspective, Russell, it might be worth thinking about why you take, say, a Spiriva or another symptom controller every day, and what does that allow you to do?
Yeah, well, it's interesting. My three main medications are Oxys, Symbicort, and Spiriva. And I guess for me personally, the one I noticed the biggest difference with is the Spiriva. I can't tell you why, but I'm sure you probably can.
Yeah. So that's a long-acting bronchodilator, so that opens your airways up for a good 24 hours.
Mm.
So for someone like yourself that has COPD, it keeps your airways open, and the purpose of that is it reduces the symptoms and allows you to be active.
Which I like to do.
Which would work that you like to do. Yeah.
Exactly.
So that's the basis of treatment for people with COPD is it helps your symptoms and allows you to be active, allows you to get on with your life.
So in summary, medication that is targeting more asthma-like symptoms are targeting inflammation.
Yep.
And with fixed airway disease like COPD, they're targeting relaxing the muscles and keeping those airways as open as possible.
Yeah, exactly. Yeah, so they're targeting the symptoms and enabling you to live as normal life as possible. Because as you're well aware, the more activity you do with airways diseases, the stronger your lungs are going to be as well. You don't cure conditions by being active, but you allow yourself to be at your best.
Well, that's exactly right. And medication to me is the important part of that. You can't go out and be active and do the things you want to do unless you've got that medication right.
Yeah. So I guess the commonality between the asthma and the COPD is that there is not really any getting away, for the majority of people, there's not really any getting away from daily medication. But the daily medication, hopefully, stops you needing to take breakthrough medication, the reliever medication. So if you're controlled on your daily medication, for the most part, the medications are clever enough to keep your condition controlled and enable you to get on with your life. So I guess that's probably the big breakthrough I've noticed over the last 20 or so years. Previously, we weren't as clever as getting people's conditions under control so they could get on with their lives and have it not affect them too much.
Do you think some of that comes down to patients not, how do I put it, not knowing their disease well enough, so they couldn't relay their symptoms to the doctor the way they should?
Yeah, I mean that's a good point. I mean, I guess what the disease is a label, isn't it?
Mm.
It's a label that comes from a diagnosis. What the symptoms are is what you feel. So I think it's a really good point you make. It's really important that you try and think about what is it that you have, what are the symptoms, when does it affect you, and a really big aim of treatment, and in collaboration with your doctor, is to think about really having that the way that it affects you minimised so it doesn't affect you. So yeah, I think that's a really good point, Russell, that being able to describe it and being able to relay that to your practitioner is important, because the label probably doesn't matter too much to you. Really.
No, no, it doesn't. You're right, and I think from my point of view, the more information I can give my doctor, the more informed he's going to be about what I'm actually experiencing. You know, if you go to the doctor and say, hey, I've got a cold, and that's all you tell him, well, you know, have you got a sore throat? Have you got headaches? Have you got this? You know, what are you actually experiencing? And I think it's the same with our disease. You know, everyone's going to have different symptoms, so it's about relaying those symptoms to the doctor.
I think sometimes these labels can actually mean that we get a little bit, you know, lazy with being able to describe it in a, you know, more effective terms. So if you go to your doctor and say, oh, my asthma's playing up, and then the doctor's then thinking, asthma, you know, okay, I need to treat it with medication. But if you can be more descriptive and saying, I'm having real trouble with breathing at night, and it's making me quite anxious, and I find that my inhalers aren't effective at the moment, then that's a much more descriptive way of thinking about your condition, and that sort of enables a more descriptive response.
It's so true. Actually, you just made me think back to my own diagnosis before I went to see my respiratory specialist. I thought that the problems I was having was just my asthma getting worse. So I guess if I went to the doctor and said, hey, my asthma's getting worse, what can we do? It's different. Whereas I said that this is different to my asthma, I'm experiencing these sorts of symptoms which I haven't experienced before, which then determined, all right, there might be something more going on than just asthma.
And I think that's really important because, unfortunately, there's still a lot of people that die from asthma and respiratory conditions. And what's we're seeing is that the older generation is where those deaths are occurring. So that maybe part of that is people thinking, oh, I just can't do what I used to be able to do, without thinking that there might be some sort of underlying, you know, issue there with their breathing.
Well, yeah, I guess as we get older, we're not able to do the same things. And I know of patients who have got older and they've put on weight and they've got more breathless, but they've put that down to the fact that they are getting older and they're putting on weight, and that's why they're getting more breathless. Yeah. But there's actually been an underlying problem there. And I guess, you know, that's part of the message is think about, you know, what things have you done in your life that could affect your breathing, and could that be smoking? And even if you'd given up smoking, you know, 10, 20 years ago, that can still have an effect on you later on in life.
Yeah, very good point. You know your own body yourself. If you feel that something's not right, if you're getting a little bit more puffed going upstairs or walking up the street or running for the bus or whatever it is, you know, if you get a cold in winter and it's affecting your airways a little bit more, or even, you know, you're waking up in the middle of the night and you just feel a little bit puffed. Get that checked out. They're all signs that maybe something else is going on. And it's not that you're just getting a bit old or you've had too many pies.
Exactly. So moving on to, talking about inhalers, delivery systems. So we touched on that before. We've now got a variety of different ways to deliver medication. Can you go through some of the more popular ones that we see?
Yeah, sure. We think of a good way to describe inhalers or delivery systems, as you say, is metered dose inhalers, so MDIs. And that really describes that you're getting a metered dose, you're getting an exact amount in each time you actuate it. So within that, there's your standard Ventolin type thing, so they're pressurized ones. They're called PMDIs. So Ventolin and the serotype inhalers, they're very much the medication that's mixed in with a propellant, just like a fly spray or anything like that. It's the same sort of what you'd expect. The change, I'm trying to think how long ago now, 20-something years ago, is these dry powder inhalers. And it's still metered dose inhalers, but instead of a liquid inside that turns into a gas when you actuate it, there's a tiny little amount of really, really fine powder. And it is a tiny amount. So, you know, inhalers and accuhalers, the common brands. And some of the other ones like the Spiriva that you mentioned that you were having, and that's a dry powder that's within a capsule. So the turbuhalers and accuhalers, they have the dry powder within the entire inhaler, and they're in a sealed place. Because remember that we're talking about dry powder, and dry powder doesn't like moisture. It's got to be in a sealed place. So you either have it in a capsule like Spiriva, or within the turbuhaler or the accuhaler. And that's pretty much it. The newer ones that are coming out are these sort of mist type ones that are still a pressurized metered dose inhaler, but the idea of the dose coming out, it comes out at a rate that's more equal to what you want to breathe it in at. So when old style ones come out really fast, and then
That's interesting because I've a little while back I changed over to the Spiriva Respimat, the mist delivery, and what I found with using that is the timing of inhaling and taking in that mist is a lot easier, because of the flow of the mist is not as quick, so to speak. But I could see that some patients, it may be too slow for them, their delivery, and they may not be able to get their technique as good as it should.
Yeah, do you know what? It's probably a good time to talk about flow rate, breathing flow rate, actually, if we're going to talk about that. Because the metered dose, the pressurized metered dose inhalers like Ventolin or the mist ones, you really need quite a slow inspiration rate. And I know people that don't have a lot of lung capacity probably have a slow rate anyway. The person you hear on the train behind you going really quickly and sucking it in, they're probably breathing about 3 times the rate that's effective. So a slow rate, maybe a good rule of thumb is it would take about 5 counts, count on all your fingers to have that one breath. So it's a lot slower than you'd expect it to be. Now the difference between that and the dry powder ones, the dry powder, you actually have to use your breath to suck that little bit of powder out of the chamber and get it in, which means you don't breathe in slow when you're having the dose. You start off fast, and you certainly don't build up from slow to fast. You actually start the dose fast, so you'll hear a sort of right from the start, whereas the pressurized metered dose inhalers are much slower. Very, very different. So what can be quite difficult is if you have people that use 2 or 3 different types of inhalers, and they have to think about a different breathing rate for each one.
Yeah, well, that's true, and I guess I fall into that category, but I guess I'm lucky as far as I'm able to get a good dose of each one. With those different delivery devices, is there any that's better than the other? Or I guess we've probably answered that. It really depends on the patient.
I think you got it in one there. They've all been designed to try and each new one is designed to try and make it that little bit easier and that little bit less reliant on the person doing the right thing. But at the end of the day, the person still has to do the right thing, and you could have the most high-tech inhaler and still get a very, very small amount of the dose. You can have the old school style ones and get the maximum amount of the dose. So what's the answer to this? Get it checked. Get it checked regularly. Think about it. Do it in front of the mirror. Get family members to check you. So, what are you doing? This is the way I'm doing it. This is the list of things that I have to make sure I do correctly. Am I doing those? Because we all get into bad habits. We're busy. There's things going on, but I really kind of I like to relate it to when I'm teaching students that relate it to cleaning your teeth or flossing or things like that. when you're in a hurry, you race through it. You know you do a poor job, but when you actually stop and think about it, you're aware and you think, oh, I really miss that side, or I never floss, or I hardly do the bottom, or all those sorts of things. And I think it's the parallels with using the inhaler. You have to do it every day, and how you do it makes a big difference.
Yeah, that's exactly right. As far as technique's concerned, is that something that a patient should discuss with their doctor or with their community pharmacist like yourself? How do they go about making sure they've got the correct technique?
Yeah, you could do a doctor or a pharmacist. It depends who has the time. Certainly, I think with, I can only speak as a pharmacist, when you're giving out the medication, if someone's coming in to buy it, then it's a perfect opportunity because you've got it sitting there right in front of you. So I'd quite happily say, it falls within the pharmacist skill set and to support people and help them do the right thing. But I think it's the onus is also on the person to say, hey, can you please check how I do this, because I really want to make sure I do it correctly. And there's been masses and masses of research into how the little things that you do wrong make an enormous difference to the amount of medication that you actually get in to where you need it. So whether you shake it or not, or sometimes so for a turbuhaler, making sure you hold it upright, vertical when you actuate the dose, having that seal around the mouthpiece, how you coordinate it, how you breathe out, whether you hold your breath after you dose and then breathe out slowly, and the weight you have between doses, all that makes a huge amount of difference to getting the right amount of medication where you need it. And that sort of goes back to what I was initially talking about, is having the smallest dose that it keeps you gives the most effective result and allows you to be at your best.
Yeah, and they're important points. I think there will be many patients out there that may overlook the importance of taking their medication and using the right technique and the timing and all those things that you've talked about. And really, if they can get all those things right, it's only going to help them manage their disease better and feel better.
Without a doubt. Unfortunately, there's been some studies that show a lot of practitioners are just as poor at using inhalers as the patients they're trying to teach. Unfortunately, so
is that like the mechanic's got the worst car in the street syndrome?
Yeah, something like that. Yeah, imagine having a person with a respiratory disease who was a practitioner. It's a dual problem.
Exactly. In regards to medications, is there anything new that you see coming onto the market, new developments in medication, or are we going to be looking at even more improved delivery devices?
Yeah, it's a good question. There's nothing that I see that's a real breakthrough that's going to cure people or really stop them needing to take inhalers. Unfortunately, I'm sure sometime down the track something's going to come up. There will be some breakthroughs, but at the moment I'm not seeing it. The big differences in recent times have been the combinations, so putting inhalers together, different molecules together to get an additive result, which is just as good or better than the two inhalers separately. And that's been a big thing for cost, for ease of use, and just allowing people to get on with their lives. And I guess so it's the combinations. The other thing is longer acting molecules as well, longer acting drugs. So that means that people only have to take them once a day.
Yeah.
So they're the big differences, and I think we'll probably see a little bit more of that in the next little while, more of those combinations, more choice of different types of inhalers. So I guess it allows an individual to get something that's really suitable to them. So suitable medication that comes in a suitable device and enables them to take it in the least amount of times per day.
I guess we've talked a lot about inhaled medications. I guess one topic that comes up a lot in forums that I'm involved in is prednisone and its use, and more importantly, its side effects. Are there things that people have to look out for as far as taking prednisone? And I guess, first of all, what does prednisone actually do?
Well, prednisone's an anti-inflammatory, so it's still a corticosteroid, just like some of the ones that are in your inhalers, but it's at a much higher dose, and it's oral. So the other ones are obviously inhaled, so they go directly to the site, which means you can get a much smaller dose because it's it hits the airways where it's needed. But when you get to a stage that that's no longer working for whatever reason, because your condition's got worse, or you're having a bad time at the moment through having a virus or whatever it is, then sometimes people need something that is a little bit heavier, and that's where prednisone comes in. And for some people, that means everyday use of prednisone. I guess the same sort of ideals as what I was talking about with the inhalers, the preventer inhalers, is you want to get the lowest dose that gives the effect you want. Prevention can make a difference, so effectively taking your preventative inhalers can sometimes reduce the need to use prednisone, and that can be really effective. So people are at their best when they get exposed to a virus or whatever else is making it worse. Occasionally, even with the best prevention and the best treatment, there still is a need, and that's when you need to take prednisone. Yes, there are side effects. Unfortunately, it is a case of weighing up those benefits and the risks and the benefits for someone that's not breathing are very real. Does that answer your question, Michael?
It does. It does definitely. Yeah, and I guess that's the way I look at it. Is prednisone is I guess a go-to medication when you are having an exacerbation that your normal medications can't help. But I guess the point is the quicker we can get on and off prednisone, the less impact those side effects are going to have.
Yeah, and I think that's it. It's just trying to minimise your exposure to it, but also having enough that enables you to get over, whatever it is that you're having with that particular exacerbation. So it's the old rule of thumb that be at your best for when hard times come. So it's sort of banking some good airways. So when you need to spend it. And being at your best means, taking your preventers that enables the inflammation to be at its lowest, or taking your preventers for COPD that enables you to be active and have your airways, at their best. Your breathing's good. You're in and out. You're able to walk or exercise or do whatever it takes to keep you at your best. Have your vaccinations as well, and that all put together hopefully minimises the amount of prednisone that you have to take. With that in mind, we shouldn't also be afraid of prednisone. It's the doses of steroids that were used in times gone by were a lot higher, and they were a lot less specific, and we knew a lot less about them. So nowadays, the idea is to keep it specific. As you said, keep the time that you need it, at as short as amount of time that's going to be effective for you, and then get back to being
a healthy person.
A healthy person for that, yes.
Exactly. Well, this is all really good information that I'm sure people are going to get a lot out of. One thing that I like to ask the guests on the podcast: if you, Steve, were diagnosed with a respiratory disease tomorrow, what's 3 things that you would do?
Yeah, that's a good question. If the practitioner patient becomes the patient. Do you know what I do? I'm going to say three things that are a little bit not what you'd expect from a pharmacist. The first one is get support from your family and friends, and maybe even others that have similar conditions. So don't try and do it yourself. Make sure you've got a good support network around you, because sometimes having a severe respiratory disease means you actually need to call on others. So make sure they're around you. The second thing is get a good team of experts. So build those relationships with your doctor or your pharmacist, your specialist, your physio, and also make sure that they talk to each other as well. So they're not, and you're all part of that conversation. So they're not sort of all working in isolation in silos. You're all coming together for a common cause. And the third thing is something probably close to your heart, Russell, is try and maintain or increase, if possible, your level of activity. So it's certainly much harder to maintain it or increase it when you've lost a bit of it. So try and be at your best, and some of that's taking medications, and some of it's just getting out and about and getting on with life.
Yeah, look, and they're great points, and I especially agree with the number one point is having a support network around you with this disease is very important. I know I certainly wouldn't have the quality of life I have now without what I call my team around me, which is my wife, my kids and extended family, and my doctors and my pharmacists. So all those people need to be part of your life and part of your network, so you can put all the other things in place. Well, Steve, that's a great bit of information, and I want to thank you very much for sparing some time with us today. We've probably gone a bit longer than I thought I would, but it's all been very interesting. So I guess topics like that, you tend to talk about them a little bit longer than what you think.
Yeah, I agree, Russell. There's lots to talk about, and maybe 40 minutes isn't enough, but I've really enjoyed talking to you.
Alrighty, so that's it from this episode of COPD Wellness with Stephen Hughes, and all about medications.
Thanks for listening to today's episode. Remember, you can connect with Russell on the COPD Athlete Facebook page or check out copdathlete.com.
Be sure to tune in next time when we continue to explore chronic obstructive pulmonary disease.
Thanks for listening.
Bye for now.